We want always to cure, and whenever we are not able, this is for us it's the difficult part for our work.
Fellow Homo sapiens, EEGs haven't changed much over the past 10 years, but the understanding of the information that they provide has improved massively. From today's Epilepsy Sparks Insights episode, learn from paediatric neurologist and epilepsy surgery specialist Luca De Palma about how epilepsy surgery isn't experimental anymore. It is a treatment. We speak of how there are still issues regarding access to surgery for many people. Luca also tells us about how he manages things when a child isn't suitable for epilepsy surgery, because that does happen.
Hello Torie, thanks again for letting me speak to all the public. So I'm Luca De Palma, I'm a 40 years man who is dedicated the last 14 years to epilepsy, and in particular to epilepsy surgery and intracranial evaluation.
Could you tell us first of all how intracranial EEGs and epilepsy surgery have improved over the past 10 years since you started, basically?
The technique about epilepsy surgery and in particular intracranial evaluation of EEG did not modify too much in the sense that we do not have a really new hardware. We are using the hardware that we have in the past 10 years, but nowadays what has changed the maximum is that we know really better how we are safe, so that we have large series, we have bigger data. We know from series about more than 500, 800 intracranial evaluation, that intracranial evaluation are safe, they do not harm per se. So really we have now we know better what we are using, and we can speak to people better to what are the side effects, which is the risk, and especially which are the benefits that are very solid. It's no more experimental, it's really normal, clinical, and therapeutic tool.
Are the number of people who are having these EEGs, these intracranial or stereo ones, has the number increased over the past few years?
So there is really difficulties in increasing the number. The problems are several for a lot of country specific. It's well known, for example, in Italy there are not so many centers that can do this. So the number of centers that can propose this solution, this therapeutic tool, is not so wide range, and so at the end the number of procedures that can be done are not so much. Then there are other problems related to reimbursement, the cost of the exam, that are very much so. I mean, it's always the same old stories, but up to now there are a lot of difficulties in increasing number, and so the fear is that there are a lot of people with epilepsy that cannot have this therapeutic tool, and they are still waiting for it. Some centers in Italy, for example, have up to 2 years of waiting list.
Gosh, and in those 2 years, a lot can happen to a person with epilepsy, especially the complex ones.
Yeah.
And sometimes I think lots of people aren't aware that you can have, especially young children, can be having 400 seizures a day. Sometimes, and 2 years is a long wait for that.
Fortunately for children, we do not have this waiting list. For example, in our center, we have a very short, very short waiting list, and so for children, it will never happen, but I mean, there are children, there are adults, everyone have to be treated in the fastest as possible. So and with the better tools as possible,
which actually saves the public money over time, because people are being rushed to hospital less, or A&E less, and all these different things, fewer injuries. So what does the future hold, though, in your in regards to your career and EEGs in general, where do you think we're going to go? Because I think over the past 5-10 years, things have accelerated in terms of technology exponentially. You can actually see beautiful looking EEGs now, and the pictures that are created are just extraordinary. And especially when also, merged with the data from an MRI, for instance, it's just beautiful. Where do you think we'll be in another 5 years?
I think that almost all people already have experienced these things, because everyone has a smartphone, and the smartphone has the tool that has changed the smartphone is the way they calculate everything. So the artificial intelligence that will help both people with epilepsy and doctors to understand better what's going on, and to have a better fusion of the data. So as you already know, we discuss in a meeting all together, and we make all our experience all together to have a final decision. But in the future there will have automatic tools that will help us in deciding what should be done and what should be not done. But especially because people are always worried about having this automatic tool, but the things that I think that the future will be that they won't say you have or you cannot have, but they can give you a probability of what is the best option to be done and which are the risks, with more solid probability. So up to now we discussed that as 70% of being seizure free with 1% of risk, but these are generic, not people specific, while we will move towards a really people specific approach, in which a person specific approach, which each person should have the personalized way of being treated, and will be not the standard one, it will be his way, and the way that will assure the best option, so reducing the side effect and maximizing the benefit that you can have. And this will be really the future then, so everyone could have the best treatment in not every part of the world, because there will be some difference, but really a more widespread use of the most advancing tool, because these tools could be used everywhere, because the moment they will be available, they can use by everyone.
Yeah, it's so easy to, relatively speaking, to get hold of just a phone and an app. I was speaking to somebody involved in the industry, shall we say, recently, who'd been working with a patient who said that they only had 2 seizures a month. And then they used a specific device that wasn't on the phone, but it was like a mobile partial EEG. And they were having 19 seizures a day, but didn't know, an average of 19. And I just thought, wow, that's amazing. I think first thought often for people is, oh my God, that's awful. But actually, okay, it's certainly not a great thing to be having so many seizures, but isn't it amazing that now that data can be shared with their clinician for more effective treatment? And I guess that's kind of like complements what you've just been saying, is that we can merge all this information and then figure out which patients are most suitable for surgery, what will be the benefits, or, why might a person not be suitable for surgery? And then we can redirect them. Do you have to do that sometimes actually in your work? You must have to say, actually, sorry, mate, your child is not suitable for surgery, and you have to redirect them.
It's the most difficult part for us, because in some way we want always to cure, and whenever we are not able, this is for us it's the difficult part for our work, because we have always to really not to be so sure of ourselves, and decide every time whenever it's too risky, and we have really to suggest not to go to surgery, despite not going to surgery could means you will still have seizure, but it will be really less harmful. So this is the most complicated part in speaking with people who have to suffer for epilepsy. So this really, but I mean, we have always to remember that we have to do the best for them, not for what we think, but it's the best for them.
And what happens with those people, rather than you solely saying, sorry, can't help you or can't help your child? Do you redirect them to somebody else who can help them?
Yeah, we are lucky that we have a comprehensive program that does not include only epilepsy surgery, but it's a comprehensive program that includes all the advanced treatment with drugs treatment, neuromodulation treatment. So it's we will take care 360 degrees about his problem, and if it's not surgical, it won't mean you are not you have not to be followed here, but it will simply mean you will have other paths to follow to try to reach the best care as we can.
And that's a lovely way to end this conversation, I think. Surgery is not suitable for everybody, although it will be potentially suitable for more people when we get more data, as we were mentioning before. But you're not forgotten just because you can't have the surgery. There are other things involved. And just like the epilepsies in general, again, it's not solely about seizures alone. It's about, psychiatric comorbidities, the impact on cognitive function and stuff, as previously mentioned. Absolutely fabulous. Thank you so much, Luca. We will include links to your profiles below this recording, so just check it out, everybody. You can also check Luca out, obviously, on the website. And we look forward to following you and hearing more about your work in the future.
Thank you very much. Yeah, it would be lovely to have another conversation with you.
To learn more about Luca, check him out using the link below, where you can find multiple links to his profiles and his work.